Ladies and gentlemen, the event will begin in about 5 to 10 minutes as we wait for other participants to log in. I am Dr. Kiesha Prem, an infectious disease modeler at the 𝗧𝗲𝗰𝗶𝘀 School of Public Health at the National University of Singapore and the London School of Hygiene and Tropical Medicine. And I'll be your MC for this conference. Thank you. Good morning, good afternoon, and good evening to everyone joining us from all around the world. Welcome to Day 2 of the Precision Public Health Asia 2021 conference. I am Kiesha, and I'll be your MC for this conference. Today's event would not be possible if it weren't for the generous support of our sponsors, platinum sponsors Illumina and Roche Pharmaceuticals, gold sponsors Novartis and Sysmex, as well as Amazon Web Services, Health Catalyst, and AIA. We would also like to acknowledge the support of our partner institutions, the American Chamber of Commerce in Singapore, the College of Public Health and Occupational Physicians of the Academy of Medicine Singapore, IQVIA Singapore, and the Singapore chapter of the International Society for Pharmacoeconomics and Outcomes Research, ISPO, as well as our media partners, Asia Pacific Biotech News, Asian Research News, and Infomed. I'm sure everyone found yesterday's session engaging. We discussed how some of these emerging technologies and traditional tools could be shared and transferred across borders during peace and war times. We also explored the challenges and opportunities faced in bringing precision public health technologies to low and middle income countries. As we have new participants joining us for the first time today, allow me to quickly run through some of the housekeeping announcements again before we begin today's program. This is the 3-day conference, and we're currently on day 2, and there'll be 2 virtual plenary sessions with panel discussions. During the panel discussions and as the speakers are sharing, you may submit your questions through Slido, found on the right-hand side of the screen. You may also vote for questions submitted by other participants. Please note that all questions will be moderated. Before and after the plenary session and during the intermission, please feel free to visit the virtual exhibition booths, connect with other participants at the networking lounge, and share your thoughts on the engagement wall. We received many questions from yesterday's panel discussion, which we could not address because of time constraints. You can share these questions with other participants on the engagement wall and hopefully continue the conversation there. Also, stand a chance to be one of the 10 lucky winners to each walk away with a 200 Apple e-voucher. Find out more about the participation rules and guidelines by clicking on the Rewards tab. Finally, please tag your social media post with the conference hashtag PPH Asia 2021. Today's first plenary session, Technology for Good, Why Work Together, is kindly brought to you by gold sponsor Novartis. The session will explore public and private partnership as key elements in deploying precision public health, as well as how innovations that have already been developed and typically applied more aggressively in the private sector can be used in combination with public data set to support health systems. This session is helmed by Dr. Hsien-Hsien Lei, Chief Executive Officer of the American Chamber of Commerce in Singapore, and also an adjunct professor at the 𝗧𝗲𝗰𝗶𝘀 School of Public Health at NUS. Prior to AmCham, Dr. Lei was the Vice President of Medical and Scientific Affairs at Medtronic Asia Pacific, where she was responsible for the Medtronic Innovation Centers in Japan and Korea, training and education, and the company's health system transformation strategy in the region. She also has an extensive experience in corporate communications, advertising, and promotion, as well as government affairs. I will now hand over the time to her. Dr. Lei, please.
Wonderful to be with all of you today and to open up the morning with very exciting plenary session. Let me introduce our speaker and panelists. First, Dr. Taha Kass-Hout, who's Director of Machine Learning and Chief Medical Officer, Amazon Web Services. Dr. Taha Kass-Hout is a physician executive with a successful track record in transforming healthcare, public health, life sciences, precision medicine, and genomics. He's Director, Machine Learning, and Chief Medical Officer at Amazon Web Services, where he leads initiatives including Amazon Health Late, which you'll learn a little bit more about soon, and Amazon Comprehend Medical. Previously, Dr. Kass-Hout served 2 terms under President Obama, where he pioneered the use of emerging technologies and cloud, CDC's electronic disease surveillance, and established the Open FDA and Precision FDA, part of the Presidential Precision Medicine Initiative data sharing platforms, both referenced in the White House updated strategy for American innovation in 2015. Dr. Kass-Hout is also helping teams at Amazon to develop the science, technology, and scale for COVID-19 lab testing to protect associates and effectively address this pandemic. Thank you so much, Dr. Kass-Hout, for joining us today. I'd now also like to introduce first Dr. Sue Anne Toh, Founder, Chief Executive Officer, and Medical Director, NOVI Health. Dr. Sue Anne Toh is Senior Consultant Endocrinologist with almost 20 years of experience in internal medicine, diabetes, and metabolism. Dr. Toh was previously Senior Consultant Endocrinology at the National University Health System, where she led person-centered care models to improve care integration and outcomes, particularly for patients with complex medical conditions. She's a leading expert in the management of a wide spectrum of conditions, including diabetes, lipid disorders, metabolism, weight management, and cardiovascular risk management. Dr. Toh is a recipient of national and international awards, including American Heart Association Awards, Singapore's National Medical Research Council Clinician Scientist Award, and the Public Service PS21 Gold Award. She continues to be active in research as an honorary visiting consultant at the National University Hospital and Yong Lu Lin School of Medicine, National University of Singapore. And our next panelist, Dr. Jonathan Tan, thank you for joining us, Jonathan, Head of Patient Access Asia Cluster, Novartis. Dr. Tan currently leads patient access in Asia, focusing on transforming the patient's journey to healthcare. This includes going beyond the pill through the development of innovative financing models and end-to-end management programs, leveraging connectivity, data analytics, and artificial intelligence. His previous role was as the director in 𝗪𝗏𝗯𝗹, a global management consultancy, where he led the research on the healthcare, insurance, and societal impact of aging populations. Prior to this, Jonathan was head of health economics for Allergan Asia Pacific. Dr. Tan holds a BSc from University of Western Australia, a PhD in biostatistics and epidemiology from the National University of Singapore, and an MBA from the University of Newcastle. It's so exciting to be able to learn from our panelists today, particularly because, as we heard yesterday, precision public health will depend on the collaboration between scientists, researchers, and developers from different backgrounds across disciplines working together to use data generated in different regions from different patients and with different techniques. So we'll learn a lot more about that today from these experts with tremendous experience. And now, I'd like to invite Dr. Taha Kass-Hout to share the role of AWS in the digital transformation of healthcare. Dr. Kass-Hout?
Thank you very much, really appreciate it. And thank you for having me today. So I'd like to, I prepared a few slides just to kind of go over some of the work that we're doing. Let me make sure here that we can get there. It's also really great to be with many colleagues as a former public servant in the federal government at the Centers for Disease Control and Prevention, also in the Food and Drug Administration. And as a public health practitioner myself, it's really awesome to be here with all of you. So today I'd love to share with you just some of the work that we do with many of our sort of customers in healthcare and life sciences and genomics industry across the globe, whether that's in private industry or in the public sector. Many of these lessons that we learn is really being kind of obsessed about the customer in ways that we can really deliver the right solution to the right problem. Let me start with something that was really amazing to see over the last decade, where we witness digital transformation in healthcare globally, with organizations currently capturing a huge volume of patient information in the form of electronic medical records. And as you all know, medical data is highly contextual and also heavily multimodal data that are treated separately. I mean, this raw data comes in all sorts of shapes and formats that are notorious being messy, incomplete, and inconsistent, and often stored in on-premises systems. There are definitely emerging standards that we've observed over the last decade, such as the Fast Healthcare Interoperability Resources, or FHIR, that aims to address the challenge by providing consistent format about how you can describe and also how you can exchange structured data across systems. However, much of this data remains unstructured information that is contained in medical records such as medical notes, nurse notes, pathology reports, radiology reports, or documents like PDF laboratory reports, or in forms like insurance claims. Images is the widest sort of unstructured form of this kind of information, like X-rays and MRIs. And then, as we saw also with COVID, the uprise of new form of or emerging sort of structures like recorded conversations and videos being sort of propagated, and so on and so forth. And as the cost of genome goes down, we're going to see more and more of these variants make it into clinical practice and also into medical records, as well as wearables and that sort of thing. Which means the data needs to be extracted, transformed before it can be searched and analyzed for higher purpose sort of value, whether that's precise prevention or treatment, or even looking at the population as a whole. Currently, the process to extract this information is fairly labor intensive across all of our customers that we work with, and it's highly error prone. Where the cost and operation complexity is one of the most challenging sort of component for most of healthcare organizations globally. Every healthcare provider, payer, life science company is trying to solve the problem on their own of structuring this information, because if you do, then you can make better patient support decisions, design better clinical trials, or even operate more efficiently, identify population health trends. For example, if you look today, the most widely used clinical models, like from Framingham study or Shastak-2 score to predict one's heart risk, are all built from commonly available data from experts' opinions, but are simple features that are less than 20 or maybe even 30 data points about a patient. However, a patient's medical record today has at least 200 to 300,000 data points, including your medical notes, and none of this data is used today to manage patients or predict their outcome. And you want all this information to come together in an organized way at a point of care to build better and more accurate predictions, but also be able to roll up to the population as a whole to be able to manage the population of patients. And globally, there are about 21 million people on blood thinners today. If a third of those don't need to be on it by coming up with a better score than Shastak-2 score, for example, then you could potentially prevent 250 to 300,000 brain hemorrhages a year. So we have this sort of mission on how we can help alleviate a lot of this heavy lifting for many of these customers, because we do believe that reading the entire medical record leads to a better clinical decisions. For this, recently we launched a new technology in a form web service called Amazon Health Lake that really helped transform this data seamlessly and allow many of these organizations to easily identify trends and make predictions, and then also support interoperable standards like the Fast Healthcare Interoperability Resource, or FHIR. This interoperability ensures that health data is shared in a consistent, compatible format across many applications, where the Amazon Health Lake creates a complete view of each patient's medical history and then structure it in the FHIR standard in order to facilitate the exchange of this information. One of the biggest element is the unstructured notes. For example, medical notes, or such as triage notes, or nursing detailed notes, or pathology reports, or radiology reports, and that sort of thing. Where we build technologies, integrated natural language processing, to easily and accurately tag, index, and structure this health data to keep an updated index on the entire population. We've developed this technology using machine learning that has been trained to understand and extract meaningful information from unstructured healthcare data, where you can automatically extract entities such as medical procedures, medications, tests, also entity relationships such as medication and its dosage, or entity trait like positive or negative test results or the time of procedure, as well as protected health information data from medical texts. That way makes it a lot easier for researchers and public health organizations to share that information for a wide variety of research purposes. For every medical entity that we extract, since this is totally driven by machine learning, is we do provide confidence score to provide full transparency. And the output, as you can see on the right, we start from totally sort of block of text, and you have on the right where you end up with highly structured information that's easily analyzed. And having this level of detailed granularity really improves efficiency and throughput for a wide variety of use cases, where we've seen this for things such as population health analytics, medication reconciliation, revenue cycle management, and population health analytics. Ontology mapping is another key feature where we help extract all the features and then map it to the appropriate ontology, such as ICD-10, RxNorm, CPT, or SNOMED, with high accuracy and low latency, where associated medical codes are added to help identify, for example, medications and their brand names, or ICD-10 codes used to further analysis for billing, or for population health sort of cohort analysis and building, as you can see in this particular example. The Amazon Health Lake, then, what it does is really help you hum with the wide melodies of this kind of information come in from all sort of sources and then create a concerted view on every patient that's organized on a timeline, where every dot in the sequence is indexed, tagged with newly structured data, as well as stored in a respective sort of file resource, whether that's for encounter, for example, outpatient or inpatient, or emergency room, lab order or test, procedure, medication, etc. So now you can not only search and apply advanced analytics, but can also predict a bunch of interesting things with new machine learning models on all your data, not just a subset of it, to help manage the entire population. Without having to build a new data set every time you want to build a new model, whether that's for cost efficiency or health outcome predictions, or on the entire population of entire data of the population. So the benefit of doing this can be multiple folds. I mean, now we can make these predictions faster than you would previously. So that way you can intervene more quickly and improve care and reduce costs, such as predicting someone's risk of heart disease, or optimize patient flow. And then through the FHIR-enabled APIs, healthcare providers and public health agencies can easily share and access data. And then also for patients, consumers, be able to have unfettered access to that information, or be able to share with third-party applications and that sort of thing. Now, one thing very, very important is AWS, Amazon Web Services, is very vigilant about its customers' privacy and data security. It is job zero for us. AWS customers retain ownership and control of their content, along with the ability to encrypt it, protect it, move it, or delete it in alignment with their organization's security policies. AWS extensive security technologies and rigorous attention to securing our own infrastructure are designed to provide each customer with control over who has access to this data. AWS never accesses information unless directed by these customers. Additionally, customers enjoy building their own secure applications on this infrastructure, as it provides the most comprehensive cloud to support their machine learning workloads. That's from data store, security analytics, compute services, and more. Today, we offer over 500 features, for example, and services that are really focused on security and compliance, including over 100 HIPAA-eligible services for healthcare customers and certifications for IT industry. And with customers managed keys, GDPR compliance, HIPAA eligibility, you can really be confident that patients' data remain secure and their privacy is protected. Next, I would like to show you a couple of examples about how customers are using our services to build better predictors. So let's look, for example, drive an impact with work we've done with Cerner. Cerner is a one large electronic medical record provider and population health analytics platform. Together, we're able to develop a model using a 24-month observation window on a large cohort of 121,000 patients. These are heart failure patients plus their control. There was further validated on about 215,000 CHF providers globally. And we've done the cases and control using certain criteria, for example, between age of 40 and 70, with 3 encounters for ICD-9 code for 28 over 6 months. And by adding features of ICD-10 codes and RX norm extracted not just from the structured part of the record, but also from the medical notes, we're able to improve model accuracy by 4% with significant reduction in false positive and false negative. Overall, we were able to predict congestive heart failure 15 months in advance with area under the code of 92% accuracy for patients and populations. And one of the amazing things is when you look at the structured part of the record, these are common things such as patient demographics, like gender, marital status, health, clinical conditions, procedures, medications, and observations. But what's really more important that got us the boost in this model was the unstructured part of the data, where we use ICD-10 codes and RX norm extracted from medical notes, but also indication of social determinants of health. Here you can see clear difference between, on the left, how medical conditions were highly unspecified when you only looked at the structured part of the record, medical record. Whereas on the right, you can see the data embedded within the unstructured notes for patient extracted by integrated medical natural language processing, far better classified. This otherwise would have been a false negative case for this particular patient. And by including when demographics and social determinants of health were added, you can see how populations start really to separate. Or we also, do to demystify which features went into this model and how, for example, these could drift over time, therefore really removing the black box out of the equation, where not only you can assess biases and model output, but you can also look what went into it in the first place and how each feature is influencing the model over time. I'd like to kind of touch basic quickly on some work that we've done also with around COVID. Machine learning is really great to look at highly unstructured and highly sequential data, and that's health data. But when it comes to multi-sources of information, this multimodality of information, finding reasoning across time, can become really a daunting manual effort. So what we've done last year is we put together a search engine powered by machine learning with a strong biomedical understanding of the natural language questions. For example, you can ask questions such as, what's the severity of COVID-19, and you'll be able to find answers in a way that where you can identify association, for example, with IL-6 protein. And when you ask the question, what regulates IL-6 protein, you can really get down to the mechanism of action of the disease. Today, we have indexed over 130,000 research papers and other material growing at a rate of about 250 to 300 new publications every day. I can really imagine our understanding of COVID in January of last year versus today, and how the evolution of that, where you have an engine that can really understand those connections and be able to kind of build that knowledge graph for you, while you can interrogate the answer by using natural language queries, where a lot of researchers, doctors, and clinicians really enjoy access to this kind of level of information. COVID-19 remains a relatively unknown disease with no historic data to predict trends. So for this purpose, we also built an open source a disease progression simulator and several machine learning models to help test the impact of various interventions. There have been breakthroughs understanding COVID-19, such as how soon an exposed person will develop symptoms and how many people on average will contact the disease after an index case is exposed. So the wider research community, however, is while they're actively working on this, actively predicting the percent of population is exposed, recovered, or have immunity, it's still a lot to be learned from the data itself. And this is an uphill battle task for many of them to accurately model and capture all the complexities of the real world. So for these reasons, we have now open sourced these tool sets for researchers and data scientists and public health practitioners to better model and understand progression of COVID in a given community over time, where this tool set is comprised of data progression simulator and several machine learning models to test the impact of various interventions, such as mask wearing or closures and the immunity level of immunity in the community. The machine learning models help bootstrap the system, estimating the disease progression, and then comparing the outcome to historical data, but then also allow you to run simulation with learned parameters. So basically, we'll learn all the parameters around incubation, for example, about spread, about and give you a wide range of tools or levers to be able to play these what-if scenarios for various interventions. As you can see in this diagram, we illustrate the interactions among the extensible building blocks of this tool set. Machine learning can accurately learn simulation parameters, interventions such as transmission rate, transmission control. These are learned from configurable range by reducing the simulation error for validation time frame with known cases, but also learns key interventions such as fitting confirmed case counts based on what you already have seen in the community or observed case variations, and then be able to also learn from different kind of signals around the world. For example, it could be one city in United States can be compared to another place in India or in Europe, and then how we can really learn from those sort of interaction and where the machine learning is constantly learning. A couple of things is just kind of a couple of highlights is we work with Moderna from the early days when China government on January 11th last year put out the printout of the virus, and within 48 hours able to leverage Amazon Web Services machine learning stack to be able to kind of design the first chemistry of the protein to be able to prioritize the top more stable ones and identify the chemistry that went into clinical trial within few weeks. And the same vaccine that was approved at the end of the year in December was exactly the first one was predicted using this approach. So this is we're really proud about that work that we've done with Moderna. Another example is about how Us Against Alzheimer's is using a well-tailored chatbot for those concerned about their own cognitive memory or their loved ones that could be indicative of Alzheimer, is how we can use all these tools to be able to personalize that journey for them, from identifying any early indication of cognitive memory issues, all the way to kind of personalize what's next best sort of interventions for them and reducing the burden on the healthcare system. And lastly, I just want to mention work that we're doing in Germany with where we collaborated with the Munich Leukemia Lab about improving the performance of their leukemia subtyping classifiers, where the performance gained about 4%. And besides achieving desired performance, is we were able to focus on delivering an explainable model that could in turn help uncover biological relationships and advancing the science of knowledge in the field, and going beyond sort of the traditional leukemia diagnostics that are based on subjective analysis of phenotypic features, and going really deep into subtyping each one of those models. And that's, again, the really great work of how they were able to build all that on AWS machine learning stack. And with that, I really would like to thank you so much for having me today, and happy to answer any additional questions.
Thank you so much, Dr. Kass-Hout. There was a lot of information packed within a few slides, so it'll be great to have some time to do some deep dives into what you shared. But for now, I think let's get the other panelists to share their experiences, and then we'll round back with the question and answers. Dr. Sue Anne Toh, may I ask you to share your thoughts on this whole dynamic of precision public health, public-private partnerships, and loads of data? Dr. Toh?
Thank you, Hsien. So first of all, I'm delighted to join you all here today. Thank you very much for the invitation. And I'd like to briefly, very quickly congratulate the organizing team on the stellar work of putting together such a interesting and highly experienced group to share learnings around precision public health, just to get us all on the same page. I think we are here talking about getting the right health interventions to the right population at the right time. I think that's been a recurrent theme even from day one. I would also argue that it's also at the right place, and there's increasing shift, particularly in healthcare systems, towards what can be appropriately and perhaps even better done in the community. And I think the past year with the COVID-19 pandemic has illustrated the importance of really focusing on efforts to anchor data collection from the community and how that can actually guide more targeted interventions for prevention and management of various health and healthcare issues that we face today. So I think I'll just briefly cover three areas that I think are crucial for public-private partnerships for precision public health and how we can leverage on technology for good. So there are the three V's, right? The first V is around vision and alignment of vision. The second V is around value creation. I think that's a key component in order for these partnerships to actually have any solid foundation and legs to run on. Thirdly, it's viability, having a viable business and operating model such that these efforts can scale and be sustainable. So I'll cover each of these areas in turn. So I think needless to say, to come together to work on something, the parties or the stakeholders need to be completely aligned on the goals and the vision. For such efforts, they tend to tackle issues of a certain degree of complexity with significant impact on the community, right? Or the population at large. Because if the problem is not big enough to be worth solving, it oftentimes doesn't necessarily require structures such as public-private partnerships to come together to solve that problem. Alignment also includes alignment in values, value systems, and the objectives, and seeing the value of each other. In other words, the different partners involved, each has to truly see how complementary expertise, capabilities, and capacities can come together. And that brings me to the second point around value creation. How can then coming together result in results and impact that can be greater than any one entity could have possibly achieved on their own? Right? And last but not least, even the best of intentions and the most capable partners coming together, if there wasn't careful thought put into how it can be sustainable, what are viable operating and business models such that it can be propagated and be scalable and sustainable. Otherwise, a lot of times we run into the issues of running successful pilots with great outcomes, but then there are limitations to how far it can go beyond that. So I think I was asked to share about some specific examples from personal experience that could be illustrative of some of the success factors, as well as I think, I wouldn't say failures, I guess sometimes it's a mindset. If we see things as challenges, then even if it didn't necessarily accomplish the long-term outcome that we intended, but we learned a lot from it, that's not necessarily a failure per se. So I'd like to share with you a couple of examples from the past, the present, and some of the upcoming work that we plan on doing in the future. So thanks, Hsien, for the introduction. I think as you've heard, I am currently with a startup that I co-founded with two other public health and preventive medicine clinicians. But prior to that, I was director of the Regional Health System Office at the National University Health System, where we were tasked with overseeing the strategic planning and development and bringing different stakeholders together to implement programs towards improving health of a population, but also we felt very strongly about putting into place better systems for collecting outcomes of interest that can be both quantitative as well as qualitative, because otherwise, how would we know which efforts actually make sense for whom and when, and how best to channel resources that, of course, are always limited to the ones that could benefit most. So I'll share one example from my time at the Regional Health System Office and paint sort of the background to the problem that we were trying to solve. So in Singapore, we have both the public healthcare system as well as the private healthcare system. And in primary care, at least as of 7 to 8 years ago, a lot of chronic diseases were shouldered or managed in the public healthcare sector. And the primary cares, the GPs in the private sector would do a lot more acute care, coughs, colds, etc. This in part is also related to our healthcare financing system, because there are government subsidies for citizens and permanent residents of Singapore, in which medications, lab tests, doctor's consults for chronic conditions would be heavily subsidized in the public sector, and hence the out-of-pocket payments would be a lot lower, even if you were to see a specialist in the public sector as opposed to a GP in the private sector. However, with the increasing burden of chronic diseases and an aging population, we know that this is hardly sustainable. And how could we better shift this balance, but also empower what we know to be a very capable primary care workforce to better take on chronic disease, patients with multimorbidities and chronic diseases, but also enable and support this transition of care from the hospital setting to be anchored in the community, where they would theoretically be able to access care more continuously. The system where you have a family medicine doctor or a primary care provider who knows you in the context and environment and the communities that you live in, as well as your family members, social networks, etc. There is definitely a merit in helping you improve your health more sustainably when those systems are in place. So when we were operating out of the hospitals, we really wanted to look for like-minded private primary care partners that we could work with. We identified quite a few, and one program that we rolled out together with a private sector primary care partner called Frontier was a family medicine clinic. And this was also a scheme or program that was funded by the Ministry of Health in Singapore. And the construct was that in order to facilitate this public-private partnership between public sector hospitals and a private primary care entity, the government would step in to fund for a period of 3 years, right, any deficit funding that's required to implement these new models of care. However, the expectation is after that 3 years, the private primary care partner would be expected to be able to operate somewhat independently and find a viable, sustainable business model to carry that forward. So what were some of the key learnings and experiences that we had? Well, I think one, it really illustrated how when there's a good alignment in vision, we found like-minded primary care partners who really were very patient-centered and saw the importance of this common goal that we were trying to achieve. It did take a lot of mindset change to even get buy-in from specialist providers to transition or refer some of the patients that they were seeing in a hospital, and to give them confidence that we do have good primary care partners in the community that would be able to manage them and manage them well. It also involved the hospital providers providing adequate support to our primary care partners. I think this was greatly facilitated by a shared electronic medical record system that we sort of opened up to this particular partner. You see, in Singapore, whilst we are all working towards a national electronic health record, today, and especially at the time, a lot of it was still pen paper notes, and then we were just moving to electronic medical records. And then the hospital systems, each hospital may have a different one, and our primary care partners would be pen paper or operating on a different electronic medical record system again. But as you can imagine, if you have a patient with multiple chronic conditions, having this ability to share this information, if one provider changed a medication or was thinking about something or spotted or identified certain risk factors or social determinants of health, if one could share that information responsibly, then of course that would affect a better care plan and care delivery for the patient or client at the right time in the right setting. So I think this was a key enabler that really facilitated both information exchange to care for the patient, but also shared learnings and upskilling on both ends, right? Family medicine clinicians have very unique skill sets that can serve our patients very well. And they do appreciate, though, getting some inputs and support from specialists where needed, but not necessarily having to send the patient back to the hospital at all times. So cutting long story short, this model actually ended up being quite successful. We transitioned thousands of patients from the hospital setting with chronic conditions such as diabetes, heart disease, history of strokes but stable, etc., over to our primary care providers. They demonstrated that they were able to look after these patients equally well, if not better. Clinical outcomes indicators were good. And we also tracked healthcare utilization, which, as you all may be familiar with, is largely driven by hospital admissions, ED visits, etc. And truly showed that there was, after a period of time, cost savings overall in the population that was being looked after through this patient-centered care model, right? So those were all the good things. And then what happened? Well, at the end of the 3 years, you see, there's a huge financial gradient between what the patient would pay out of pocket if they were to see the specialist in the hospital, as opposed to seeing a private primary care in the community. And that meant that if they were on medications and labs, etc., they would likely end up paying more out of pocket, continuing their care with this excellent primary care provider in the community, rather than if they were continuing their care in the hospital. That was just one of I think several, other more systems-based or systematic or systemic factors, right, that related to the healthcare ecosystem at large that we would have to grapple with. And at the end of the day, this proved to be an almost insurmountable issue or challenge, because obviously it was not necessarily in the patient's best financial interest to continue in this manner, even if all the elements of the care model made sense. It did evolve. I think over time, there were different mechanisms or programs, such as the primary care networks. I think in the context of this particular session, I won't have time to go into all the details, but I guess we do iterate and learn. And I guess what it has transitioned to is trying to find best fit models to continue some of this work, but perhaps not exactly in its original shape and form. Right, so I think one key learning there is, despite the alignment and vision, clearly there was value created for the stakeholders, the patients, the healthcare providers, and the healthcare system, because even cost savings and improvement outcomes was demonstrated at the systems level. But we were still challenged because it wasn't necessarily a very viable financing or business model for some of the stakeholders involved, namely the patients as well as the private care providers. We did, from a hospital health system, sort of regional health system office perspective, try to support this transition, but ultimately, again, we can't continue to fund these efforts indefinitely, right? So having a viable system to be able to make sense for all the payers involved is also one important consideration in the sustainability of these different partnerships. Okay, so that's one example from the past. I'll share another example of something that is past to present. The efforts are still ongoing, and that involves a research program around the development or progression to type 2 diabetes. This is a research study called Assessing Progression to Type 2 Diabetes. The acronym is APT2D or AP2D. And this research program is jointly supported by an industry partner, Janssen, or Johnson Janssen, as well as the National Medical Research Council of Singapore and the Yong Loo Lin School of Medicine, the National University Hospital, and the National University Health System. The objective of this research program is to delineate different trajectories in the development of type 2 diabetes. So to have a prospective observational cohort of individuals who have normal glucose levels, as well as those with pre-diabetes, glucose levels that are higher than normal, but not so high to be considered diabetes, but are thought to be a precursor stage to the development of full-blown diabetes. Now, we know that not everyone progresses at the same pace, right? Some people do progress to full-blown diabetes, others don't, and perhaps reverse. In diabetes, even though I'm an endocrinologist, and that's the most common condition that endocrinologists see, I'll tell you that who cares about diabetes if it doesn't result in other complications that could kill you, such as heart attack, strokes, kidney disease, certain types of cancers that are correlated with lifestyle factors, as well as eye disease, etc. Right? So if we could better delineate who are those that are likely to progress to complications and target those and put more stratified effective interventions, because it's definitely not a one-size-fits-all, both in terms of the medications required and the medical treatments required, as well as because it's a lifestyle-associated disease, the various different habits that one and choices that one makes on a daily basis that would modulate the interactions between your basically your behaviors and biology to ultimately determine whether or not you progress along a certain trajectory for development of disease and its complications. Okay, so here, where was the alignment in vision? Well, Janssen, J&J had a very clear strategy towards not just wanting to develop efforts to treat diseases when they happen, but also what they consider disease intersection, where you pick up factors early, intervene early, and change the course of disease. And that was highly aligned to the concepts and the problems that we were already seeing as practitioners. So there was definitely that alignment in vision. Value creation, well, there was joint resources put in. So Janssen did contribute significant support and resources to fund this research program. And the National Medical Research Council of Singapore has a grant funding mechanism called the Industry Alignment Fund that is anchored on the premise that if you have an industry partner putting in a certain amount of resources, the National Medical Research Council would match that resource by a certain percentage as well. And then we would jointly agree on certain outcomes, milestones that need to be achieved. So this worked quite well, right? And then I think in the collaborative agreements, it spelled out the patient's data, the participants' data does not belong to anybody in particular other than the person itself. They always obviously consent to having their data used for research, but they can withdraw the use at any time. The National University Hospital, the university, and the health system are the custodians of that data, and the industry partner would have access to certain types of data for specific use cases that was delineated in our collaborative agreement. So there's a win-win for everyone, but in a very responsible, transparent manner, and that we could all see how we brought different expertise to the table and that we could all benefit from each other's inputs towards an effort that is unprecedented. What's unprecedented is that in this study, we are following thousands. So we recruited over 2,300 individuals and performed in-depth physiological studies where we are measuring how much insulin one is making and how responsive one is to insulin, the two fundamental defects that occur in the development of type 2 diabetes, as well as multiple other data points are being collected about their lifestyle behavior, sleep, etc. And this is a huge multidisciplinary team effort. There are a number of investigators from the School of Public Health involved in this effort. And I have to also give credit to the School of Public Health for seeding some of these early efforts many years ago. Okay, so where are we now? We have successfully completed the recruitment for the study. It is on track, and we're due to complete our last visit because there's a follow-up period of 3 years for the development of type 2 diabetes, right, by the end of 2021. We have already reported some really exciting preliminary results and data at the American Diabetes Association scientific session some years ago, and we're in the process of having our first paper peer reviewed at present. But what it is contributing is a wealth of data around trajectories of diabetes development in an Asian population at an unprecedented level of depth, incorporating both an assessment of biology, behaviors, and factors related to social determinants of health. Okay. In this instance, I think it was very clear who was doing what, and that the milestones also were very clearly laid out. So it seems like a relatively straightforward model. I think what it took was also a lot of trust and credibility on the part of all the stakeholders, and that really eased the workings together and really enable everyone to just focus their time and efforts on doing productive work without getting too bogged down about things that tend to suck up and drain a lot of time and energy that can be distracting. All right. Okay, so last but not least, I'll share a very, very sort of early example, and we still don't know how that's going to end up, but we are very excited about what the future could hold. I shared that I've co-founded a health tech startup called 𝗪𝗲𝗋, and the mission of 𝗪𝗲𝗋 is to reverse chronic diseases and empower healthier living through the use of health technology. Okay, so essentially we bring together both the medical and lifestyle care components to more effectively impact on a person's health behaviors in a manner that would alter their risk for developing disease and complications. We, during the COVID-19 pandemic, worked with our clients include individuals, so it's both B2C, patients themselves can sign up to be part of the program. It's also B2B, employers, insurers, various other organizations can sign up groups of individuals or their population onto the programs. And we also co-develop a number of different products with B2B partners that are aligned with this end vision of reversing or reducing the burden of chronic disease. One example is when we partnered with a government employer during the COVID-19 pandemic to deliver a digital health solution that really supported these individuals with their chronic disease management, diabetes in particular, as well as weight management during a period where there was relatively more limited access to traditional healthcare providers. At the same time, this model continues to run and had started prior to the pandemic, but I guess the pandemic did accelerate some of the use cases and the adoption levels to the point where the pilot was very successful in demonstrating good outcomes, improvements in HbA1c, which is the average blood glucose levels over a 3-month period or so, reduction in weight, and importantly also qualitative experience in terms of the participants reporting that the nature of the intervention really met their needs when they are busy working individuals in a pandemic setting where they may be also holed up under different conditions, and it may not be so easy to make the best choices for themselves in terms of food, physical activity might be more limited. But having this very personalized coaching to guide them on how to make smarter choices on physical activity, suggestions that they could work on even at home using resistance bands, a chair, a table, etc., really did make a tremendous impact. So small changes, but repeat every day, really over even a period of a couple of months, resulted in pretty significant improvement in clinical outcomes. We are now very excited to work on scaling up to increase the reach of this program to more employees within the organization, and also sharing some of these learnings with other organizations down the road and seeing how it can be implemented. We've learned a lot about how to better screen a population to see about those who might benefit most. So it's not just about ICD codes or having a diagnosis, but also perhaps a certain level of interest or activation, because you can't help those that don't necessarily want to do anything at the time. But I would posit that out of 10 people, we can probably still activate or help a large majority, at least 8 out of 10 people. But there may be 1 or 2 that it's just not the right time, not the right place. And it doesn't mean that you give up on them, but just right at this time, it may not be the best fit for a particular intervention or program. Okay, so I'm going to pause there. I think I probably talked for about 20 minutes or so in a monologue, which is a little bit unusual. So I'm going to stop there, hand it back to Hsien, and be happy to take questions later during the panel discussion as well. Thank you.
Thank you so much, Dr. Toh. You had so many different experiences to share with us, but there are a couple of things that we'll get to later. I especially want to talk to you about the usage of data and availability. But for now, I would like to invite Dr. Jonathan Tan to share with us his experience with public-private partnerships. Dr. Tan, over to you.
Thanks, Hsien. So hi everyone, right? So it's really fun session to be in. So I'm from Novartis, a Swiss pharmaceutical company. And I guess pharma usually contributes to the treatment or hopefully more precision medicine as part of precision public health, right? But I do believe there's a very valuable role of pharma to play in precision public health beyond just providing the treatment, right? And that is by contributing, typically I would say, and ideally through public-private partnerships, right? And Dr. Sue Anne has spoken about various different types of projects she's worked on, and Dr. Taha as well, right? So I mean, I think for me, the PPPs and precision public health work really well where there's a win for all. And if I could steal Dr. Sue Anne's model of the 3 V's, right, where the vision, the value creation, and viability are all very much aligned, right? So ultimately, it's about how the healthcare system, the hospitals, the providers, and pharma and the industry, and it could be a technology partner as well, are aligned on the goal and they all benefit. Right? So I would like to share one example we've done recently, and really it's a very nice one where it involved the public sector, technology company, pharma, they all came together. So in Novartis, we have we have treatments for a variety of eye diseases, right? And many of these eye diseases, traditionally require large, specialized, expensive machines to detect, right? And then the results need to be analyzed by specialists. But as a result, you can imagine that in many rural parts of Asia or just rural parts of the world, these treatable eye diseases go undetected, right? Many patients are undertreated and ultimately lose their sight. So, we had a good opportunity. I met some people in Samsung, and Samsung has this group that develops really very cool, health tech, digital tech solutions, right? And they had developed a portable eye screening device. So it really was essentially a handheld camera connected to one of their Samsung smartphones, right? In addition, they also developed the AI-based algorithm to analyze these photos, right, that they could take of the eye to automatically detect 5 different eye diseases with good accuracy. Right? So you can imagine that this is a really great opportunity for a much lower cost portable solution to at least do the initial screening of eyes. So essentially through PPP, we have now introduced this technology to 2 hospitals in Vietnam in a relatively low cost way of screening patients for eye diseases, right? Allowing more efficient identification, referral, and ultimately earlier detection and treatment for these patients. So, and you know, if we come back, like, why do we need this PPP, right? And why is PPP needed in maybe something in precision public health? And really, as reflected in this example, right, I think a key part of precision public health is supporting the healthcare system to identify the patients, right? And this could be through diagnostics tests in this example, or in sort of database, big data analytics, right? And then ultimately somehow, how do we manage, you know, help the patient better manage the disease, right? And this, you know, the way I see it requires typically improvements in the healthcare system, right? A combination of both physical infrastructure, policy changes, and also even in the care delivery or the management of the patient, right? And so then the question becomes, can the healthcare system or hospital do it alone, right? And I'm sure in many instances they can, but in reality, resources are limited, right? And so with, especially with something like precision public health, I think there's also a level of complexity that requires capabilities that the healthcare system often may not currently have, right? And so I think that's where the PPPs come in and are really valuable, right? So you can bring in knowledge, technology partners into the solution, right? And in the example that I shared, right, where we ultimately worked with a technology company to introduce a new method of identifying patients in the healthcare system, I think the reason why it worked is because it was a win for all, right? And as Dr. Sue Anne Toh mentioned, the vision was aligned, right? Value creation in terms of value, you know, Samsung had developed a great product, but they were looking for application outside of Korea, right, where their, you know, their footprint in this field is much smaller, right? The hospital recognized that there was an unmet need, right, and they were willing to adopt a new solution, right? And for us, you know, we understood the challenges of the healthcare systems. We know which hospitals are suitable for such partnerships and are open and willing, right? And actually also in Vietnam, we have, you know, treatments for our eye diseases that are already reimbursed by the government, right? So it's a very nice, let's say, environment or situation, right, to bring everyone together, develop these solutions, and ultimately deliver better outcomes for the patients. And I think, you know, of the 3 V's that Dr. Sue Anne Toh mentioned, right, I think a very important factor is the viability or ultimately the sustainability, right? And particularly the sustainability of funding, right? And in most cases, I would say everyone has to be willing to contribute, right? So in this example, Samsung and us, right, and Novartis cover a large part of the upfront costs, right, to get the product registered and ultimately paying for the upfront cost of the equipment and maybe some training. The hospital obviously also had to contribute in terms of the staffing and running of the clinic, and I would like to think the commitment to keep running the clinic. So, you know, if the success of this program would have been dependent on, you know, long-term external or industry funding the running costs, I would say that honestly, it would probably not be viable in the long term, right? So, yeah, I think maybe one key piece I kind of think about with PPPs is that I think industry has a really nice role to play to help with the startup, the acceleration of it. But ultimately, you know, I would say the broader healthcare system will also need to be committed to taking on some of the longer term costs, right? So and that's where I think that PPP then starts to work really well together. So maybe I'll just stop here with my example and maybe some of my key thoughts, and hand it back to Hsien.
Thank you very much, Dr. Tan. That was really great sharing and a nice link up with Dr. Toh's 3 V's. So we have a running theme there on the 3 V's. I would like to encourage everyone to go ahead and answer your, put in your questions into the Slido format on your screen, because I am seeing them and I'm letting them through. And the top vote getter is a question around government. And the interesting thing about public health, I think most of us who end up going into public health are fully aware that we will need to work with government. In fact, we must work with the government in order to be able to operate at scale and to influence policy that benefits at populations at that level. Right? We're not talking necessarily about individuals, although they make up the population. So that first question about government is actually incredibly important. And we have folks here on the panel who are extremely experienced in working with the government. So I'm going to broaden the question a bit more than just a focus on data privacy. I would like to start with Dr. Kass-Hout. Your experience with the Obama administration, that's a tremendous amount of work that you had to do. I remember the days of when the website was being put up, the Affordable Care Act in the very early days. I mean, what would you say to folks who are interested in collaborating with government? I mean, there are ways in which we definitely have an aligned vision when we are from the private sector, but there are other ways when government can feel that it can feel that governments are putting obstacles and roadblocks in our way when private industry is moving fast and wanting to get things done. What are your thoughts on working with the government? You're on mute, Dr. Kass-Hout.
Yeah, thank you very much for the question. Just so putting my old hat, prior hat on at the FDA, the Food and Drug Administration, we're working on the President Obama's Precision Medicine Initiative. Was he was very passionate about and keen on patient access, full access to their information, and having patient in the center as decision makers and equal participant in their health journey. And the challenge was on us as government agencies was how can we tailor our approach to these new approaches, for example, about, there's more data available. There are techniques like machine learning, next generation sequencing, how regulation and innovation become part of the same sentence. And it is really a challenge that was worth taking, and we took on. And as a result of that is what you see today about, various now with the 21st Century Cure Act, data liquidity, and how data should move more easily from a healthcare provider to another healthcare provider, patients unfettered access to that information via modern ways about, through application programming interfaces. I mean, who thought we would see APIs and regulations? So all those are very, very important, but the main focus was how can we fast track innovation in the ways we can, deliver the right information to the right individual at the right time, and you're right every time, and then start tailoring treatments and preventions to that individual based on a multitude of environmental as well as personal health journey and family health and that sort of thing. And then for the regulatory bodies to be able to keep up with the pace, but also be an equal participant in this, about how you can, for example, regulate by standard-based approach. This is the so-called analytic validity and clinical validity. As of today, for example, if you're building a machine learning model or predictive model, however which way it is, you need to be able to trust that the model is going to be accurate and then over time remains accurate. And because in the real world, data shifts, your assumption shifts. So this kind of drift in the information as well as drift in your prediction. You need to be able to how you can monitor this. And also, as data about individuals make it into these models, then you need full transparency into breaking this black box and to, for example, understand not only why someone's risk went up for a certain thing, but why their premium went up. So this is a very, very keen, and for us at Amazon Web Services, now shifting my other hat where I am today, we're on a mission to demystify this black box, demystify machine learning for the masses, for software developers, for data scientists, for the public, to be able to kind of, you want to bring the right tool to the right problem, and it's the data becoming more and more complex, the resolution of this information becoming more complex, all the way down to your molecular level. and then be able to kind of deal with this mass amount of information. Majority of it's unstructured, majority of it is complex, and then how we can reason across all those. Well, machine learning is great for those types of problems you can bring. But you can't do that if you don't have. I mean, oftentimes these skill set exist in academia or exist in large companies like Amazon and others. And how can you really work together about providing this next level of generation of technologies that enabled by machine learning to do the right job for the right purpose. This is like, for example, the work I mentioned earlier about the Munich leukemia lab, or the work we've done with us against Alzheimer with their brain guide to really bring global awareness about Alzheimer and how you can detect it early. And if you can detect it early, what are the right personalized next step sort of resources that might be tailored to you? And if you look at the FDA, I mean, it's really amazing to see, even with the pace of COVID, but generally about how open they are to these data-driven approaches, and these algorithms make it where you are now put in the regulatory stance around a standard-based approach, like how well if you have a benchmark, did you meet the benchmark or not? Like everybody else is, why didn't you meet the benchmark? As opposed to kind of getting more into the sort of traditional ways about how you can organize these. And today's we're seeing diagnostic make it into things at home, things that you wear, like EKG on a watch that can really bring more awareness and more engagement with patients. And you want to see more of those. But also respect that the government has a role about making sure that not only you sniff out the snake oil, but also the digital snake oil. And again, back to the value chain of this flywheel, public-private partnership becomes even more important, and the role of the government becomes even more essential. Because at the end of the day, like when I used to wake up every morning when I was at the FDA, was patient safety and and making sure that what's put out in the market is the right thing for those right consumers. And if you believe in that, then you're going to try every way possible to bring everyone to collaborate around that mission. And so what a wonderful mission for us all to tackle together.
Thank you so much, Dr. Kass-Hout. I love that you closed with that mission on ensuring good patient outcomes, that people really are able to achieve the best health they can. I'm going to go to Dr. Toh now. I'm going to build upon what Dr. Kass-Hout said about bringing the right tool to the right problem, because you and I had a little bit of a conversation in the preparation for this session that sometimes when we are meeting with government stakeholders, they believe we have the right tool. We think we have aligned on the right problem to solve, but they also think when you're coming from private sector, that you also have unlimited resources when it comes to money or product or services. In that sense of working with the government, and also just generally in your experience of working with the government, Dr. Toh, what would you advise folks who are about to embark on this idea of a public-private partnership?
Thanks, Hsien. So, I think the government, especially when we think about public health, right? I think we would all agree that the government has an absolutely key role to play there, right? And what people often think about, whether it's providing, let's say, large amounts of funding or free product, I think taking that sort of brute force approach, I think it really isn't sustainable, and I think most people would see that, right? I mean, an extreme or a simple example would be if we were to provide, free medications, for a country, right? The reality is we know that the access to the medication still remains very limited in most countries, right? Primarily because there are just so many other access barriers in the healthcare system, right? Whether it's diagnostics, whether it's the patient not being referred to the right center, treatment, and then patients not staying on treatment, right? So we know that, right? And Novartis has done quite a lot of work, particularly in the developing markets, looking at global health, right? And this is the issue, right? And so then I think it comes down to really that topic around health system strengthening, right? Which is how can we improve, strengthen the healthcare system to ultimately improve and shorten the patient journey, right? From the time they get the disease to the time they get the right treatment, right? And And as part of that, I think, you know, industry has a very nice and important role to play. But, you know, I think coming back to the role of the government, it is about the sustainability of these solutions, right? So we can help fund the initial setup of the solution. We can even provide certain amount of treatments, right? But there's just so many other components along, let's say, a patient's journey, right? That, you know, it needs, I would say, the government's presence to connect all the stakeholders, all the dots together, right? And you know, I think for that, you know, looking beyond, it goes way beyond, I would say, funding or having a cheaper treatment, right? It really requires systemic sort of changes, and certainly that's where I think we really need the role of government to play.
Thank you so much, Dr. Tan. Dr. Toh, I'm actually going to pivot a little bit to, leverage your experience in caring for patients with diabetes, because we know that's an extremely complex disease. And when you're tackling complex NCDs for public-private partnerships, things evolve over time. And some of the questions that we have from the audience is around social behavioral differences between nations, around social determinants. All of those are actually incredibly important in the treatment of diabetes patients. Maybe I can ask you from a diabetes NCD point of view, and for some of our international audience, prior to COVID, Singapore had actually declared a war on diabetes, which I believe is still going on. So if we're talking about a war on diabetes, how are we going to accomplish that when we're dealing with an evolving 3 V's, vision, value creation, and viability? Then you add in COVID and social determinants. I don't know, just talking about it confuses me. Dr. Toh, what are your thoughts on that?
Yes, yeah, Hsien, yeah, you're right. It's complex, which is why I guess public-private partnerships has a potentially very important and significant role to play. I think we started the session saying, hey, you know, what sort of problems are well suited for public-private partnership? It has to be of a certain level of scale, complexity, as well as potential for impact. Put it sort of breaking down the complexity. There is the medical components, and then there are the behavioral lifestyle components, right? So if you talk about then interventions, there's medical care, there is lifestyle care. If you talk about the underpinnings for whether or not a disease state manifests, as well as whether complications manifest, then there's the biology, including genetics. But then for lifestyle-associated diseases like diabetes, we know that the genetics, the biology, maybe contributes about 30% of the ultimate risk for outcomes, whereas the behaviors can actually modulate a large proportion of that risk, 60 to 70%, in fact, right? And a good sort of example of how that can play out even comes from the diabetes prevention, the DPP study back in 2002 that showed that in people with prediabetes, randomized to either placebo, lifestyle intervention, or metformin, one of the most common drugs used for diabetes, right? Guess what? Yes, of course, metformin worked a little bit better than placebo, but lifestyle intervention trumped everything and actually had the highest efficacy in terms of preventing development to type 2 diabetes. And then subsequently, we also have the follow-up studies that shows that it has a legacy effect. So it is well known and established that it can make a huge difference, in fact, more than the medications at times if caught early. But why is it so difficult to effect? Well, we all face this on a daily basis ourselves, right? The best of intents and theoretical knowledge, we're all, I would think, relatively perhaps health literate, but you still face challenges in terms of implementation of those choices on a daily basis. I think there are other sessions in this conference that talk about behaviors and nudges, etc. So I think it would be great to learn from some of those sessions as well. But it is this complex milieu of understanding biological determinants, social determinants of health, and then understanding that is not enough, right? It is then how do you translate that understanding into effective interventions? And then the interventions have to be sensitive to the cultural context and the communities by which these populations that we are managing or targeting operate in. Now, I've lived and worked in the United Kingdom, in the US, Southeast Asian, a couple of different countries before spending the last 12 years in Singapore. And so I can tell you that even for diabetes, the average, if there's such a thing, there is no such thing, I suppose, but the person that walks through the door looks very, very different. When I was practicing in Philadelphia, also known as Fat City, right? Very, very different from the skinny fat person that walks through the door. And it doesn't mean that the skinny fat person does better. Actually, sadly, we know that the prevalence of diabetes and the prevalence of diabetes complications is far higher in Asian populations than it is in Western or Caucasian populations, even though the prevalence of obesity, which we know is highly correlated with diabetes, is a lot higher in these Western populations, right? So that is where I think a lot of the big problems demand innovative solutions, and that's where the PPPs really can play a significant role in effecting. If we can effectively combine the expertise, as Dr. Taha shared about, the ability to leverage on skill sets related to machine learning that can integrate and make sense of very complex data sets, knowing what data makes sense that could actually impact on the outcome that you care about. Otherwise, you just end up with rubbish in, rubbish out, and lots of noise, and thinking that you have interventions that could work, pouring a ton of resources into it, only to learn that it doesn't, and we have no idea why. I think that would be the worst type of experiment to do. I think an experiment that fails is not failure if you've learned something meaningful that you can then channel to make it a success down the road. But I think going into any experiments, going to any partnerships, it's important to be clear what outcome, what hypothesis one is testing, be open to change and iterations. That's the nature of the messy, complex problem that we deal with, such as diabetes. But at the same time, being very disciplined about reviewing what the data is telling us, what insights we're getting, and how do we then tweak the solutions such that they can be more effective, and then also cost effective and efficient such that they can be sustainable.
Thank you so much, Dr. Toh, for helping us clear up some of that complexity. And I'm going to keep building on that because you did mention the idea of being able to do some predictive and analytics prediction models. Dr. Kass-Hout, there's a question from the audience about AI-led clinical prediction models. And I am imagining that it would be incredibly helpful for NCDs, but I'm gonna give you a two-parter question. So the first is on AI-led clinical prediction models. And the second one is about those geographic differences that Sue Anne mentioned, because she was talking about Philadelphia being Fat City, which I did not know because I'm from California. But the other part of it is we're in Southeast Asia, and there's so much heterogeneity amongst the populations in Southeast Asia. So when you're talking about AI-led prediction models, clinical prediction models, how do we take into account this complexity of geographic differences? Whoops, you're on mute.
Let me start by saying, thank you so much for the question. Let me just start by saying that the AI machine learning is not magic. It's really all about the data. And when you bring the data, shame on us if we don't understand the biases in that information that made it into whichever sort of downstream utility you want to do, whether you're predicting something on the population level or the individual level. Now, AI is really great for where it is today for three things. I mean, it can deal with highly unstructured kind of information. So this is where natural language processing, natural language understanding builds on decades of advanced science and technology. And because of the cloud was invented by Amazon, is now you can take that at much greater scale, and with advanced science around the newest techniques of machine learning, such as deep learning, which is highly accurate, requires very little sort of tweaking to really get down and understanding a lot of the context. So you can start appreciating and bringing that tool to the health space. AI in medicine is not new. I mean, it can go all the way back to the very first sort of psychiatry assessment bot. Goes back, ELISA, back in the early 60s. If you look at 1978, there was the bot or interactive sort of questionnaire back and forth that was able to be some of the most experts and specialists in infectious disease to predict and detect sepsis in a hospital, right? But today, when we talk about machine learning, we're talking about these advanced algorithms that really are able to discern and be able to kind of classify or predict with very little hand holding and labeling and that sort of thing. So this is a good tool to bring when you have highly unstructured nature of the data, which is what healthcare is all about today. Very little structure, and a lot of the information is highly structured, like images and notes and that sort of thing. But also machine learning at state today is where, dealing with issues such as pattern recognition, as well as forecasting. So if you take those three sort of really awesome components, marry that with regulations that are really progressive. I mean, one of them is HIPAA, where put in the patient, the ownership of the data in the patient's hand. I mean, imagine that same model in 1978 for predicting sepsis that was developed in one academic center. They couldn't transfer that somewhere else because of the ownership of that information. So HIPAA is a good thing, and you can look at now GDPR and other things. All these are progressive regulations to allow the safe and responsible way about how you share this information, and also how you can share these models and be able to validate those beyond just one institution or one geography or one place. Now, one thing for us is over the last 5 years in Amazon Web Services, we've been as I said, we want to make machine learning so boring any builder should be able to pick that up. And that's a novel mission, and it's a complex one, because at the end of the day, we want to demystify machine learning, but also in it is be able to break that black box. So, for example, in my earlier example about you need to know what went in the model in the first place to understand the outcome of that model, and then how is that drift over time in the real world, whether the data drifts or the model itself is learning new things. So getting full transparency into every feature you were able to extract, and what is the score around this? What are the features where inside this model, and where's the bias? So, for example, you might look at insurance premiums and see they're much, much higher for certain population. Could be potentially because of their zip code, or because of their country, or because of their race or ethnicity. And that's a very novel discovery that you need to do, because otherwise is you bring this data in, and then you get this model, and you're going to trust the model is doing what it's supposed to do. But in reality, there's a lot more hidden biases. So this is something that with our machine learning services like SageMaker, and this is a managed web service that we offer at AWS, is really to get really deep into the model from when you bring the data in, is understand the biases. And as you develop these models, of set of models or hundreds of thousands of these models, understand for every one of those what went in those models, and then be able to detect the bias early on in the training and the building. And then as the model is deployed, then be able to kind of really track that over time. And that's something of a great responsibility on all of us to be able to do this. But now we're really trying to demystify all this for those who build these models and understand those complexities. So I just like want to end with I hope one day we don't talk about machine learning as the goal, but it's really just a tool that helping you do better job at whether you manage your population, predict better outcomes, or reduction of costs. But have full transparency into this whole process end to end. And also machine learning, bring it on the very front end, where dealing with a massive amount of information, complex amount of information, where reasoning cross and structuring that information. Many tools like natural language processing, natural language understanding can really help discern all that, and then be able to structure in a way that now you can go and build not just 1 or 2 or 10 models, hundreds of millions of models and try all sort of things, and then understand through that process about what's an individual sort of contribution of each one of those models, all the way down to even to the cell and protein level, about would this treatment work for this particular individual. So that world is near, and I believe the more responsible sharing of information and the more of patient engagement and public-private sort of partnership will really try to help us now fast track and leapfrog this precise or precision medicine and precision public health.
Thank you so much, Dr. Kass-Hout. You've gotten me so excited to learn more about machine learning, because I want to demystify it. It's still a big mystery to me, so there's some work for me to do. But I'm excited for the students who are currently thinking about public health, who are already studying public health, and for the trainees out there. Yesterday's session, we talked a lot about the need to train folks on the tools and techniques that go into precision public health, so we can do even more to improve population health. That's what you're talking about, and I'm really looking forward to seeing what AWS can do in this domain. Dr. Tan, I've got a final question for you as we're starting to go, run out of time, but it's a very important one. It's a question from our audience, and I'm looking to the side because the questions are there for me. How could private sector solution providers move upstream to utilize innovation, looking beyond health-related data sets to promote health? What I really liked about this question is that private sector loves to talk about innovation, but what does it mean? And also, I know some of the work that Novartis has done, and it's incredible because what you are doing is moving up to that identifying patients, as you mentioned before. And sometimes of just screening them for high blood pressure. So what is this, contribution to innovation, and how is it going to help us in public-private partnerships, this balance between, what we need to do on the ground and innovation?
Oh, okay. If I got the question right. I mean, I think from the discussion today, right, I think innovation technology has a huge role to play with precision public health, right? On one hand, I think pharmaceutical companies are coming up with more and more, let's say, new innovative medicines, precision medicines, right? That target specific genotypes, target specific phenotypes within a disease, right? But if I could be very objective about it, the reality is that even with our current medicines today, right, I think the idea of precision public health will really actually allow us to maximize the use, the outcome of the existing treatments today, if we could target it better, if we could identify patients better, right? So I mean, you could take an example, right? If one of the things we're thinking a lot about is how do we better identify all these passive patients in the population, right? Could we work with a diagnostic lab, right, who has lots of data, right? Can we identify the patients with high cholesterol or high blood pressure and sort of actively identify, contact, and then manage them a bit better, right? I think that's one approach, right? Then the other piece is that, is there anything we can do to better phenotype patients? Because I think at the moment, a lot of our classification of our patients tend to be a little bit crude, right? And for us to really get down to what's the right intervention for the patient or the group of patients, we really need sort of better methods of phenotyping. And then that again links back to technology solutions that are very, let's say, efficient and scalable, right? And that's why I'm saying that all these additional things we can do today, beyond creating a new drug, a new molecule, right? That ultimately can actually drive improvements in patients' health, right? So, and I think that's the part that would be really great for us to come together to develop, right? Because I don't think any one person can do it by themselves, right? Or is sufficiently incentivized to do it by themselves, right? And maybe the additional last thought I would add in is to ensure that all the stakeholders are keeping sort of that concept of value in mind, right? Which is, hopefully people don't look at value in a very, very one-dimensional lens or perspective, right? Which is like, oh, what does it mean to my company? What can I sell more? What can I do more, right? But really, when we think about value, it should be the value to the healthcare system, right? Which goes beyond just sales of a product, the outcome for the patient, right? But to think about, okay, patient does better, but it also means lower resource utilization, which then also translates to the ability to treat more patients, care for more patients, right? And I think the holistic view of value creation, right, and the benefit is a piece that we can definitely do a lot more on, because I think as people appreciate that, then I think then the motivation or the, you know, I guess the incentives become much larger for all parties involved.
Thank you so much, Dr. Tan. I think that you had the perfect closing when we focus on value. You know, Dr. Kass-Hout, Dr. Toh, Dr. Tan, I believe you brought great value to our audience today, and I hope our audience can recognize that precision public health really is the perfect, you know, opportunity for us to bring together both the public sector and the private sector. We can do so much if we work together. Thank you so much for joining this session.
Thank you very much to our speakers for that insightful discussion. Public-private partnership, or PPP for short, can be an effective way to capitalize on the relative strengths of public and private sectors to establish precision public health technologies that neither could manage adequately on its own. As a model myself, I could not agree more with Dr. Kass-Hout's message to make analytical tools more transparent, demystify it, and publicly available for the wider community to contribute and build on. Later today, we'll explore opportunities for government agencies and industry partners to use population data from multiple health sources and develop effective targeted policies, programs, and innovations, catching and not forgetting healthy individuals, hopefully before they develop disease and become patients. To find out more, join us for the next plenary session, Nudging the Right Behaviors. Ladies and gentlemen, we'll now enter a 30-minute intermission. As you're grabbing yourself a cup of coffee or taking a sedentary break, please also do visit the virtual exhibition booth and the engagement wall, connect with other participants at the networking lounge. You may also read up more on the invited speakers and the upcoming sessions at the Programs tab. Do not forget to check out the Rewards tab and complete the activities to stand a chance to win 200 Apple e-vouchers. Please also remember to use the hashtag PPH Asia 2021 if you share any posts about the conference on social media. You can join the next session by simply going onto the Programs tab and clicking the Watch Now button next to the session title, Nudging the Right Behaviors. Thank you and see you later.